So everybody can see my slide?
Yes, we can see your slides.
Yes, lovely. Okay, so I tried to build this summer syndrome potpourri based on the multiple congenital anomalies and around the Moebius syndrome that is the dysmorphology kind of linked to classic genetics and dysmorphology. You will all get to know me much more from the organic acidemia, methylmalonic, propionic, and cobalamin disorders protocols, but I had the opportunity to see a good number of Moebius syndrome related conditions at NIH over the last few years. So for the clinical genetics, I have this presentation to share with you today. All right, so Cindy will pick the same condition for charge, but I will just skip those slides. That's fine, no problem. But they have facial weakness and they are in the differential for Moebius syndrome, so I had them here, but that's totally fine. We'll talk about Kallman syndrome, then some myopathies that resemble the Moebius phenotype, and then VACTERL. And if Ben is in the audience, Ben can talk to you about VACTERL way better and much longer, but I will cover the basics for it, and then a couple more multiple congenital anomalies syndromes. I'm sure you will hear those definitions many times, but we keep converting from syndrome to association to sequence throughout the talk. Syndrome we call something that's well characterized, constellation of minor and major anomalies that we think are due to a single underlying etiology, such as Down syndrome, trisomy 21. Association we use for anomalies that happen more frequently together, like as Cindy said, it used to be charge or VACTERL. Charge now has a gene associated with it, so it is a syndrome. And then sequence is a group of anomalies that are come from a single major anomaly, and then the others follow as a result of that. Like if you don't have kidneys, you have oligohydramnios in utero, and then that alters the phenotype of the face and contractures or others. So that's a Potter sequence resulting from the oligohydramnios. So those are common definitions. I definitely hope that these elements of morphology is uploaded to the team's website or the fellows' resources, because I always go back to this current description of proper terms to use for describing all of the dysmorphic findings for the clinical genetics exam. I still have to go back and look at how to call the ear shape and the nasal shape or the limb anomaly. It's an amazing resource. It's on our NSGRI website, and in this American Journal of Medical Genetics series of papers by Dr. Bissiker and all that you should really have easily available and readily available for you. And I put this nice, again, resource from our institute about malformation syndromes in diverse population. That's a nice place to find phenotypes of these conditions in different ethnic backgrounds. So many of those multiple congenital anomalies, of course, refer back to your standard embryology, and you will have a full semester and course on that, but depending on the timing in pregnancy that the defect happens, then you can you have the presentation of either neuronal defect, heart defects, limb anomalies, ear anomalies, eyes, external genitalia. So again, learning the embryology and the timing of the different system development is critical for understanding the combination of findings that can be seen in many of those multiple congenital anomalies. Early defects in the early pregnancy result usually in aborted fetus, so not necessarily teratogenesis. Many of these syndromes have genetic causes, many don't. So many times we have negative whole exome or genome sequencing in some of those syndromes, and we postulate, is it a germline or somatic mosaicism, or is it a combination between genetics and environmental interaction, or a toxic effect in utero. Moebius syndrome is this combination of facial weakness and then so cranial nerve 7 palsy, and then cranial nerve 6 palsy, which moves the eyes horizontally. So here the kid tries to look to the right eye cannot abduct, the the left eye can adduct. So inward movement is okay, the outward movement is affected. So this is the abducens nerve palsy, and the same on the other side. And then facial weakness, they try here to smile. This is complete facial weakness, this is a little partial. So you can smile on the lower face. So this is the minimum criteria, facial palsy and abducens palsy, and then there is a broad spectrum of associated features. So many times there are other cranial nerves involved, especially the lower cranial nerves that move the tongue and affect speech, feeding, swallowing difficulties for the kids. Cranial nerve 8, hearing deficits can occur. A small percentage of subjects have intellectual disability, autism spectrum disorders. Many have sleep issues and psychiatric behavioral issues, but the majority is intellectually intact and normal, very bright subjects. And then many have club foot, so bilateral talipes equinovarus or club foot, so where the ankles are turned inwards and have contractures and need surgeries. They can have other arthrogryposis of the hands or other joints. They have pollen anomaly, and I'll show you more pictures of that. Cleft palate, congenital heart disease, renal, GI, a range of other associated features. I have here many of the photographs of our patients, just to kind of go a little bit for the clinical genetics exam. I was going to make a note about low set ears, for example. Here, you see. You will learn that, but you look at the inner canthal here, kind of plain, all the way to the occipital prominence, and see where the insertion of the ear happens in that plane. So if it is lower than the eyes, you would say they have low set ears, and some have significantly low set ears, some don't. So then you can make a comment about the small jaw or the absence of nasolabial folds, or the asymmetry of the face. Some epicanthal folds or ptosis in some subjects, narrow mid-face. We will all do a lot of clinical exams and discuss about facial features, but just wanted to show you the range of findings of the facial exam. So this is limb anomalies. Again, here's club feet. The kid had a surgery here on the left side, and then brachydactyly, brachysyndactyly, longitudinal or transverse limb defects. And then this is the Poland syndrome that I mentioned. This is absence of the pectoralis muscle. And then ipsilateral, like the same hand can have anomalies, like can have short webbed fingers. This is just a short fifth finger on the same side with a right pectoralis muscle missing in this case. And management is really kind of supportive. They need help with feeding originally, with special nipples, special bottles. Some have need for tracheostomy or support with breathing, suction apparatus. Speech and rehabilitation medicine is important. And then they do a smile surgery where they get the gracilis muscle from the foot and put it in the right side of or left side of the mouth, one at a time, and then they can have a smile. Other craniofacial reconstructive surgeries and club foot or other scoliosis or other surgeries. So it is primarily sporadic. It can be, it's questionable if it is a genetic or environmental or teratogen exposure. We have a lot of children that were born to one or two Moebius parents, but the children are not affected. And then again, here I wanted to make a note of toxicology, exposure to misoprostol, cocaine, thalidomide, hyperthermia, maternal homocystinuria, so things that cause vascular, abnormality in vascular support in the brainstem. This is called the subclavian disruption syndrome. So different causes that can disrupt the blood supply during that critical period in development can result in Moebius. And misoprostol there is a lot of reports about misoprostol exposure. Of course, this is a medication used to cause an abortion. But of course, many women take misoprostol without having Moebius syndrome. And there is a nice New England Journal of Medicine report And this is like really, it's a phenomimic. They have very similar findings, but severe developmental delay in autism and bilateral facial nerve palsy, absence palsy, and limb anomalies. And this is kind of a misoprostol exposure kid with calcifications in the pons, bilateral calcification in the area of the abducens nerve. This is a case we saw in our protocol with misoprostol exposure, so that is a legit association, and this is the calcifications in the brainstem. Sorry, I will go quickly through that. We were able to have post-mortem exams and really look at those calcifications in the aberrant tracts of the cranial nerve 6, how it leaves the brainstem in control and memory subjects. Those are the cool things you can do at the clinical center. You can bring a patient for a full body autopsy and really phenotype to the in great detail. So this is, we said, sporadic, maybe toxic exposure or vascular anomaly. There is though a report that suggests there is 2 genes that have been associated with Moebius-related syndromes, because the kids here that are described with de novo variants, autosomal dominant de novo heterozygous variants in plexin D1 and RED3L, have a very variable phenotype. So this kid has a Poland's anomaly and Moebius developmental delay autism. This case only has mild facial weakness, and this is a classic Moebius case, but this one has ptosis and other cranial nerve involvement, so not a typical Moebius presentation. We have not found any mutations in these 2 genes in our Moebius cohort, so we currently kind of wait for confirmation for this association. So what I learned seeing these cases, and what we will always learn with the syndromes, is nobody comes with a diagnosis. You know, they come with a diagnosis, and we learned that there is a big differential, and there are cases that come as Moebius syndrome, but they really have they have cranial nerve 7 involvement or other axonal guidance disorder or a neuromuscular myopathy. So they have facial weakness, but it is not always neurogenic. It can be neurogenic, myopathic, or a neuromuscular disease. And it was very fascinating to experience that during the protocol and along the study. So the differential includes other disorders affecting pons, brainstem development, homeobox genes classically associated. HOXB1 causes isolated facial palsy. HOXA1 causes this very rare brain dysgenesis syndrome. And I'll talk a little bit more about this as in TAP3 axon guidance disorder that is related to Kallman syndrome, and cover that phenotype. And then charge, as Cindy mentioned, and congenital myopathies. So those are the cranial nerves at the base of our brain. We have cranial nerve 1 is the olfactory, controls the sense of smell. These days we hear a lot about that for the COVID-19 affecting cranial nerve 1 and causing anosmia. Abducens nerve is the one that innervates the external rectus muscle, so causing the eyes to abduct, lateral eye movement, and the facial motor nerve. And then the lower cranial nerves affect the tongue and the swallowing, as we said. So, and there are several cranial denervation syndromes. So here's the Moebius charge, can affect the facial nerves. So some kids with charge have facial palsy, and they can also have Kallman syndrome. So cranial nerve 1, anosmia and hypogonadotropic hypogonadism. Moebius affects 6, 7, the lower cranial nerves, and some very rare cases can have Kallman syndrome as well. And then TAP3 or congenital fibrosis of the extraocular muscle is affecting cranial nerve 3. And Kallman and many genes associated with Kallman syndrome affects the cranial nerve 1 and other disorders. This is the TAP3 phenotype. So this was a family that came as Moebius syndrome to the protocol, but there were the 2 siblings were in, the 2 sisters were affected. Mother was considered relatively mild or normal, but all 3 had the TAP3 phenotype. They have a certain mutation in this tubulin gene that is associated with cranial nerve 3 hypoplasia, so a different they have ptosis and they have an exotropia. They have a very different phenotype in the eye movement involvement. And then they have a peripheral neuropathy that is progressive and also absence of the cranial nerve 1 here. This is the olfactory bulbs. This is the brain MRI, the front of your brain around close to the eyes. You have these two wide olfactory, the sulci and the bulbs, and they're missing in the patient with Kallman syndrome. And Kallman is, and this is a range of phenotypes with other mutations in this gene. The kids have severe facial palsy, ptosis, abnormal vertical and horizontal eye movements, and this peripheral neuropathy. Some can hardly mobilize and can have, and it's progressive. So the Kallman syndrome that the type 3 mutation can cause is, as I said, is many, a big list of genes associated with Kallman's. Our sense of smell and our reproductive systems are very closely related in mammals and humans too. So anosmia and hypogonadotropic hypogonadism is caused by defects affecting the cranial nerves, the migration, the pituitary formation, and I will show a differential, but Cal1 is the most common gene that was originally described for Kallman. It's X-linked, and it can be associated with renal agenesis and can cause mirror movement. So mirror movements is when the right hand and the left hand move together. So you can, trying to move the right arm causes a similar movement in the contralateral side. And other genes that give you Kallman syndrome can also cause severe hand or foot deformities, cleft lip and palate, or congenital heart disease, hearing problems. And I have nice references here. This is from the gene reviews that goes through isolated gonadotropin deficiency with or without anosmia. So normosmic isolated gonadotropin deficiency versus Kallman syndrome, where anosmia and the hormonal, so low LH, low FSH, low androgens or estrogen in male or female. And here the renal agenesis, the anosmin or Cal1 is the X-linked gene with hearing loss. Charge, again, can cause the anosmia, gonadotrophic hypogonadism, facial weakness, and hearing loss. The FGF8 and FGFR1 are the genes associated with cleft lip palate and the split hand foot deformities, and then other genes. So again, X-linked, dominant or recessive, multiple genes associated with anosmia and hypogonadotropic hypogonadism. And just to show what split hand and foot is this longitudinal deficiency of the middle rays of the hand. So finger 1 and 5 or the first and fifth toe are there, but the middle phalanges and metatarsals or metacarpals are missing. So it's a split hand and foot. The other big group of differential was these congenital myopathies that can resemble, that cause severe facial weakness as a predominant finding of the phenotype. So, and myopathies can also affect the extraocular muscles, causing affecting the lateral or vertical eye movements, and with or without ptosis. So many of the, not many, a percent of the patients that came to our study ended up having one of the congenital myopathies. And this is very important, of course, because they have some are recessive, usually inheritance and risk for subject to subsequent pregnancies, and also can have risk for malignant hyperthermia or other. Malignant hyperthermia is the severe fever, severe reaction to anesthetic agents during surgeries. So it's quite important to differentiate and provide, counseling and treatment recommendations for the families. So we were able, so Carrie Feynman-Ziegler was success story where we were able to identify the gene for this autosomal recessive disease that was described as causing Moebius syndrome, PRO-bend sequence, ptosis and ophthalmoplegia, pectoral, like Poland anomaly, scoliosis, contractures, growth failure, and normal intelligence. So there were the original two siblings that were described. We see this long face, the low set ears, the ptosis bilateral here, small chin. So Pierre, I'll talk about Pierre-Robin in a minute, but we're able to see all these families in the clinical center and identify it as a congenital myopathy. So myomaker is the gene that causes Gary-Feynman zitter. Has nothing to do with Moebius. The facial weakness and the abnormal, the mild abnormality in lateral gaze was because of the extraocular muscle involvement, not because of cranial nerve pulses. And the cases have a small and retracted jaw. This is the Pierre-Robin phenotype, where the lower the mandible is hypoplastic and retracted compared to the maxilla, and they have very high, or also cleft palate, but very high arch palate. They have hypoplastic muscles, not necessarily Poland syndrome, but they look like Poland syndrome, and they have peripheral contractures and severe scoliosis, a couple of cases. And interestingly, the weakness is very significant when they are kind of born, and they need G-tubes and the ventilatory support, but then they get stronger as they grow older in childhood, and it's not a progressive severe myopathy later on. We saw a 60-year-old gentleman, and he was weak, but not progressively getting worse. He required some nocturnal, overnight he required some CPAP, positive pressure support for his sleep, but it was not a significant progressive myopathy. So there is a range. And this is the myomaker protein. It's a transmembrane protein that allows the myoblast to fuse and make myotubes. And the other interesting myopathy that was, again, seen as Moebius syndrome originally in our study was this Native American myopathy, the STAC3 myopathy that can have overlapping features, but cleft palate, short stature, scoliosis, and they are susceptible to malignant hyperthermia. So that was important to identify and treat. And other congenital myopathies, again, can have similar findings, but of course they are very severe, severe facial weakness, this U-shaped mouth, dolichocephaly, like this long, elongated face, ptosis of the eyelids. Just as an example, Nemaline or centronuclear myopathy can affect the facial muscles predominantly. And as I say, facial weakness and ophthalmoplegia, this is what is described as Moebius syndrome, but those are muscle disorders. So Nemaline myopathy, centronuclear myopathy, a range of findings that, and I will not cover that in more detail for now. I have as an example the Nemaline myopathy with the Nemaline bodies in the muscle fibers. A number of genes cause Nemaline myopathy. It's usually autosomal recessive. Some genes are autosomal dominant. And there is a weakness more severe in the face, neck, proximal limb muscles, depressed reflexes, and a range of age presentation. So Pierre-Robin, as we said, is another term and commonly seen in some of our multi-system disorders. It is the combination of microretrognathia, meaning small mandible and retracted, glossoptosis, where the tongue is kind of low set and folds backward, and cleft palate too. So again, this is a sequence because the abnormality in the mandible growth causes the tongue to be positioned posteriorly and then obstruct the palate forming. And recently, there are mutations in regions that upregulate SOX9, and I'll have a couple here which is a fascinating mechanism. We all will learn a lot more in the coming years about this structural variations and non-coding variants. So we'll do whole exome and whole genome sequencing, but those are areas that we will find in the whole genome. Increasingly, they are affect the 3D structure and bring genes that are further away in the genome together, enhancers or promoters that affect the other gene expression, and mutations in these regions have been now described to close to PAX6, causing aniridia, SOX9 associated with Pierre-Robin, sonic hedgehog, causing triphalangeal thumb and stem polydactyly. So fascinating mechanisms, and a lot more to learn how the duplications, losses, gains, or inversions can affect the expression of genes nearby, causing this range of syndromes. So we said neuronal disorders, muscular disorders, and then those are neuromuscular junction disorders that are associated with fetal akinesia deformation sequence, where the kid, as I said, could have polyhydramnios, not move a lot in utero because of severe weakness, and then have craniofacial dysmorphism, pterygia, so there is extra skin connecting across joints, like in the knees or between the thighs. So Limb-Girdle syndrome, pulmonary hypoplasia, and arthrogryposis. There's a wonderful review from March covering many genes associated with the range of this sequence, with brain malformation, cognitive dysfunction, myopathy, scoliosis, or just milder phenotypes with arthrogryposis. Highly recommend you to review this paper. And charge was covered by Cindy, so I will go really fast over those slides. She talked about the coloboma, cranial nerve dysfunction, the renal anomalies, the de novo mutation. I will just mention here golden heart and hemifacial microsomia, or oculoauriculovertebral spectrum. It's just the same disorder. We use hemifacial macrosomia for milder symptoms, or oculoauriculovertebral spectrum when there is ear anomalies, golden heart syndrome when there is more vertebral, heart, or kidney anomalies, and currently no genes are associated here with this syndrome, but you will definitely see children like this in clinic where there is hemifacial macrosomia and associated findings. So carry on. And I don't know if Ben is still on the call, but Ben has had another protocol here at NIH on the VACTER Association, and there is a whole book written by Ben Solomon, and a wonderful here review in Orphanet Journal from 2011 on the VACTER Association. So more to hear from the experts, but just for now, as a review, VACTER causes vertebral rib anomalies, anal atresia, so imperforate anus, here anorectal malformations, cardiac malformations, tracheoesophageal fistula, esophageal atresia, renal anomalies, and limb anomalies. Importantly, radial aplasia and abnormal thumb, with or without hydrocephalus, so it could be VACTER/age, and usually not severe intellectual impairment. Classically, people know this from NICUs or so. It's a single umbilical artery. It's used prenatally for the diagnosis, and then you need 3 of the above features to reach the diagnosis. So again, so this is the low set ears, anorectal anomalies, single umbilical artery, vertebral anomalies like hemivertebrae, and tracheoesophageal fistula, duodenal atresia. And this is again this embryopathogenesis, depending on the different days post-conception, affecting the different structures seen in VACTER association. And the genetics are still unknown. There is very rare reports of chromosomal loci, CNVs, and this HOXD13 removal, like a small deletion from a polyalanine tract in this gene that affects the sonic Hedgehog downstream expression. That is again a gene associated with limb formation, genitourinary, and gut development. And another again report, so rare reports that again show association with genes, the SIG3 with hydrocephalus association. And similar to the Moebius, again, several exposures like maternal diabetes, infertility treatment, estrogen, erythromycin have been reported to have caused VACTERL association. I have here the thumb radial array deficiencies because you will need to know this differential really well when radial array, like the radius or the thumb is missing. There is an important differential to keep in mind, especially the Fanconi anemia. And there is going to be several talks and discussions on that, but these syndromes, Holt Oram, is atrial septal defect with phalangeal thumb, Duane radial array or Okihiro caused by SAL4, causing limb ocular anomalies and renal in some cases, Townes-Brooks, SAL1, autosomal dominant again, imperforate anus, dysplastic ears and fan malformations, thrombocytopenia with abnormal ray, syndrome caused by 1q to 1.1 microdeletion or autosomal recessive mutation in RBM8A. So again, important differential to learn more about. So Aarskog faciodigital genital syndrome causes hypertelorism, so increased distance between the irises and the canthi here in the eyes. Shoal scrotum, which is a interesting kind of like a shoal or saddle scrotum. It's called, like there is extra skin surrounding the penis. Brachydactyly, short stature, cryptorchidism, vertebral anomalies, and intellectual disability. And this is an X-linked disorder caused by this faciogenital dysplasia, RORAC, guanine nucleotide exchange factor. It's a mouthful. So it's a lot, there's a loss of function mutations, and as seen in about 20% of the Aarskog syndrome. And last is this Branchio-Oto-Renal syndrome, autosomal dominant. This is a syndrome where you see fistulas or cysts in this branchial arch area in front of the sternocleidomastoid muscle here, and then preauricular pits, these little holes or in the ear or tags. So, and then associated abnormality in the inner ear, hearing loss, and hypoplastic kidneys. So that's the liver, left kidney, the right kidney is not there. Hypoplasia or agenesis. And then the IA1 gene is seen mutated in 40% of the cases, autosomal dominant, and its binding partner, 6-1. The report on 6-5 causing is currently disputed because the case report describing 6-5 had a CNV in A1. So that's the Branchio-Oto-Renal syndrome. And I think that's it. I say happy reading at the end. And let me stop sharing so I can see comments or see everybody. Oh, you heard about. So thanks everybody. Should I read the questions or people want to speak up? Anything, please go ahead.
Hi, this is Dee. So
Hey, Dee. Yeah.
I found it very interesting. I mean, I've heard about Moebius syndrome, I guess, but I was just wondering, there are so many different conditions that look like they present. Do you think there's a common pathway that disruption along that pathway, manifests with Poland syndrome and with some of the other cranial nerve findings that we're seeing?
So because the brainstem development, I think of the Moebius more as this hindbrain developmental homeobox kind of early developmental genes, maybe because there are many conditions that resemble Moebius that the genes belong in that early developmental gene pathways. But currently, we really have done a whole big number of whole exome, whole genome sequencing, somatic mutations. We looked for everything. We have not seen anything recurring in different families, and except for this, and then we found the calcifications in this brainstem. So this vascular disruption hypothesis is legit in some. What percentage of the cases I cannot say, but both the vascular disruption and the misoprostol association suggests some percentage of them can be environmental. Now, is there a genetic predisposition? Gene-environment interaction is unknown. And then the complex cases that have developmental delay, congenital heart defects, additional multi-organ dysmorphogenesis, we have a range of candidate genes now, and we try to match, and we have a couple interesting matches from gene matchers. So I think in these complex phenotypes that have a lot of associated anomalies, we may be able to find a number of rare variants, or unless we find a second case, or as I say, from the gene matcher, we have a couple matches for a number of those genes. So currently working on thinking, some people are doing functional studies. So we are working currently on a couple of those interesting matches, but they're not classic Moebius. They have associated findings that are atypical for the minimal criteria, the classic presentation, where people are normal intellectually and they have just the the classic findings, not the cleft palate and the atrial septal defects and the GI. There are associated findings that are atypical, and those may have some genetic, maybe genetic cause. We'll see.
Thank you.
Sure. Carolina, you heard about?
I was excited when I saw the topological domains in one of your slides.
Yes.
Because just to appreciate the importance of chromatin states in development.
Yeah, right.
And our Bar Harbor course for the past couple of days has been very heavy on chromatin. So I just appreciated when I saw it.
Great. I have not been taught all that. I'm reading about this and trying to learn and catch up, because those are new mechanisms really. And seeing that Piero Benz, is associated with that, or some of those limb anomalies, brachydactyly. So this is kind of a lot to learn. And one of our disorders, we are working on a non-coding promoter region that affects binding of transcription factors that are very specific to this. So we are working actively on one of those non-coding regions that is associated with one of our inherited forms of facial palsy. Yeah, so learning a lot on that. I'm glad Bar Harbor, obviously, they are, the latest and best right now. So I'm glad you guys are learning. You're going to teach us now, the older generation. Yeah. So Donna is asking, what is the criteria for the protocol? We were seeing congenital facial weakness. The protocol was Moebius and related congenital facial weakness disorders. So I'm glad to talk to people, but currently we're not bringing new participants for our protocol. But we have seen people with Moebius-like conditions. Everybody came as Moebius, and we were very surprised, and the families were very shocked to be told they have a different diagnosis, either autosomal dominant facial weakness or a congenital myopathy that was autosomal recessive. And the families actually had a second child that was affected, and we were glad we had the proper genetic counseling and reached the right diagnosis. So malignant hyperthermia is a significant risk, and again, telling them, because some of them have need for surgeries for strabismus or for the club foot, and it's important to reach the correct diagnosis for genetic counseling, especially. the epigenetic mutations are, yeah, incredibly hard. And this non-coding region D that we're working on, it's been 2 or 3 years, endless experiments in at Boston and Broad, and many people involved to finalize. And because modeling is very hard, mouse models don't you have the same non-coding and structural, or it's very hard to prove the causality for those mutations. Yeah, structural variations or copy number variations that affect non-coding binding of transcription factors that only express in the early development and not in current tissues. It's been a very uphill, struggle to prove the causality for some of those. Yeah. Thank you.
Irini, thank you so much. That was a wonderful presentation. Really enjoyed that.
Late in the day, long presentations, many names and syndromes. I'm sure it's hard. So we're gonna hopefully have a chance to discuss each one of them in more detail. But you're in a very good place, and NIH is the most amazing place to phenotype deeply. I mean, we have done from MRIs, functional MRIs, diffusion tensor imaging, sleep studies. It's really an incredible resource, and any geneticist or young aspiring researcher, it's a fantastic place. And you be creative, and when you see patients or join the teams for their protocols, we can always add an evaluation and expand on some or other form that interests our excited fellows. So it is a great place, and a lot of collaborations, and everybody's works great as a team, and it's a wonderful experience. So you're in a good place. Enjoy reading and work with everybody here. So
Irini, given your comment about late in the day,
yes,
patients next week, they get to make up for this because it's the 5th Wednesday and it's called Wellness Wednesday.
Okay, great.
There aren't any activities unless they can create some really safe social distancing kinds of things they do on their own. There aren't any lectures next Wednesday.
Great, the breather. I know it's hard to keep listening to syndromes, and if you don't see the patient, it's impossible to. So that's why I try to have some story that's related to how we went with the differential around Moebius, because otherwise it's just random names and random genes, and yeah, it will all make sense when you start working up cases in the clinic and have a differential. And as I say, nobody comes with a label. I have charge, or I have a Cornelia de Lang, or I have a, it's a work in progress for years, many times. So thanks everybody. Have a wonderful afternoon, and enjoy the rest of your day, I guess. Yeah.
Take care. Bye-bye.
Sure.